Hello, I'm María, a 25 years old Spanish social worker who obtained a degree in 2020 by Universidad de Granada. And as a professional experience, I've worked for a year in an association destined to 10 people affected by a neurodegenerative illness. But due to my big interest in end-of-life care and the role that plays social work, I published my first academic paper in 2021. So during the following minutes, I'm going to explain the role that has a profession in this specific area through this PowerPoint titled Social Work in End-of-Life Care. Is it possible? So moving to the index, you can see that it's divided into 5 main sections. The first one is social work functions and tools. The second, intervention with an ill person. The third, emotional intervention with family. The fourth, difficulties and intervention in communication and relation. And the fifth, conclusions. So let's begin with the first section. So the functions are, first of all, assessing and giving psychosocial support, which is assess and giving support both to the ill person and family, promoting as much as possible their welfare, showing trust and security through providing information and solving doubts, accompanying during the terminal phase, as well as during the mourning and encouraging autonomy to the carer. The second function is mediating and giving solutions in case of conflicts and giving the best and most adequate solutions or alternatives based on the patient's and family's formulated petitions. And moving to the tools, the fourth one is the interview, which encourages the feelings expression, helps to clarify the ideas and thoughts, to value both advantages and disadvantages when taking decisions, to delimitate the problem to solve it under a holistic view, having seen various perspectives, to show the observed roles and which are the disruptive behaviors and attitudes. The second is a social report that it's useful to collect data regarding to socio-economic situation as well as health and housing ones from the ill person for then doing the social diagnosis that studies what's the situation, which are protective and risk factors, families members' roles, communicational style and who's the main carer, with the finality to do the best intervention of the situation for giving the best monitoring. So moving to the intervention with a person, we have to take into account for the 4 patient's needs, which are divided in biological ones that are sleep conciliation, personal hygiene and food, the psychosocial, that is security, pertinence, feeling, love, comprehension, acceptance, self-esteem, being listened, trust, shared fears and intimacies, respect, and the spiritual need, which hold on religious beliefs, trying to give an explanation to the situation in which is involved and the sense of all its vital path. Negative consequences when giving care without help can derive to relegation due to overprotection, which is the incapability to take decisions by themselves and feeling being abandoned, which causes anxiety and family distance. And how we can help to an ill person. We can do it by to talk separately with the finality of clarifying the worries and fears both from the ill person as well as from the family to intervene with the most efficacy, to ask to the family why it decides to hide information to the ill person, to make appreciate to both parts what means that emotional situation in which they are immersed, and to allow to the ill person to vent talking about its feelings. Moving to the third section, we can see that there are difficulties to think and take decisions, which causes feeling guilty, irascible, and frustrated. There are negative emotions and searching for responsible and guilty people that is caused by dissociation when family members feel external from the situation. It can be caused to anger, persecution, and reproach, that is, make guilty the ill person due to the fact of being ill, or making guilt to the medical staff as a lack of competence and giving answers. It can be caused to turbation or confusion, that is, that family members will be blocked or they will act impulsively, and it can be caused to guilty desires and fantasies, that is, they will think that by taking care of the person, this will be recovered. And we have emotional claudication, that is, that situation in which both carer as well as the family feel incapable to tend to the patient's necessities and provide the most adequate help. Moving to the difficulties and intervention in communication and relation, we can see that there are lots of them. So, first of all, we have to take into account the types of family, which are divided in that has problems to trust, characterized by the height of feelings and information due to of the lack of trust between its members and with an absent or tense communication, that which hears but fails when listening to, because it doesn't take into account nor the feelings or the opinions of its members, and that one which is under permanent conflict, worsening even more the familiar conflicts and connivance. We have as a second difficulty the communicational process barriers. They are communicational impediments that avoid or inhibit facilitating information, counseling, or supporting families. Some carers think not annoying medical professionals because they think that they have enough with their work, and others don't want to receive external help when considering that the received information by the medical staff won't be the best for the patient. Silence conspiracy is carried out between family members, or this with the medical staff, with the goal to avoid the suffering to the patient for auto-protecting in front of other family members due to a bad communication or for the incapability of the medical staff to give bad news and facing them. And it can be divided into explicit, when it's dealt to hide information, or implicit, when it's over understood what it has to be done without the necessity of saying anything. Familiar communication, it happens when each of its members is totally overwhelmed and incapable of facing the situation which they live. It can happen at any moment and affecting emotional, health, and social levels individually as well as a group or global. And what we have as solutions. The fourth solution is model of attending in end-of-life care. The social worker accompanies a patient and family taking into account the following elements: listening to, reception, interpretation, information return, continuity, and compromise. Familiar clarification happens when each of its members is totally overwhelmed and incapable of facing the situation in which they live. We can have a mediation and counseling. First of all, mediation is the process in which at least two parts have different points of view or opinions discharging in a conflict that requires of a person with a neutral attitude to provide solutions, and counseling aims to help the person to find the best way to face the situation through capabilities, tools, and personal abilities, and is a way of making things a person who needs help through open focalized questions with the aim to take the most adequate decisions based on its values and interests. And we have to take into account three important elements for helping a person. The first one, the empathy with the person who intervenes, the congruence and veracity of the transmitted information, adapting it to the comprehension level and emotional stage in a determined moment, and the unconditional acceptance of the person with whom we intervene. So the conclusions are that palliative care is considered as an emotional overwhelming situation and difficult communication. Social work is seen as a union, support, and orienting. We have to take into account the diversity of families and need adequate interventions related to their characteristics and pursue the most welfare for both patient and family. So thanks for your attention. If you have any question, please feel free to ask to me, and you can keep in contact with me through Gmail, Twitter, or LinkedIn.